We will begin the meeting in a few minutes. We're waiting for a few more people to get here. Thank you. Anyone that wants to make a public comment, there is a sign-up sheet in the back. Please make sure you sign up on that sheet. And again, we're waiting for a few more people, and then we'll start. Thank you. Good afternoon. I'm pleased everyone could be here. You are at the Appropriations Subcommittee on Health, and I appreciate everyone being here. Our first presenter is going to be the Georgia Board of Healthcare Workforce. You can come to the table or to the podium, whichever you would like.
Good. Alrighty. Hello, good afternoon. Thank you for allowing me the opportunity to present to you. I'm Chet Bassine, the Executive Director for the Georgia Board of Healthcare Workforce. I also want to start off by saying, again, we thank you for your support over the years. We are the state agency that does a lot of work within the healthcare workforce supply and distribution, the data analysis. We extract the data from, or we receive the data, I should say, from a variety of the state agencies that are responsible for licensing, including but not limited to the Medical Composite Board that I know is here today, and we are grateful to the collaboration with these other boards. In order for us to do what we do, we need the data from them, so thank you. And we also are the agency that administers funds to a variety of hospitals and medical schools for a variety of medical education, on top of nursing schools and loan repayment, which our loan repayment programs are mainly for those who serve in populations of 50,000 and under at the county level. So just high level who our agency is, what we do. We are administratively attached to DCH. With that, what I'll do is I'm going to go through our budget recommendations from the governor and be glad to take any questions. So first is our administrative budget. We are less than 2% administrative of our total budget, so we're a small and mighty team is how I kind of view it. There's just one item. It's a statewide adjustment, so it's not just for us. It's section 17.11.1, and it's just an adjustment to agency premiums for the Department of Administrative Services administered insurance program. So it's an increase of $61.49, and that's it for the administrative budget. In the next one is our, and we have 6 programs in totality. Our next one is graduate medical education. There is a few things going on in here. What I'm going to do is just list them line by line. In 17.12.1, it's one-time startup funds for rural OB-GYN. It's a removal from last year. So again, that was just one time. And again, the same story at 17.12.2. It's one-time startup funds for a development of a pediatric rural training track. That's a reduction of $50,000. And then the next line item is line item 17.12.3. Increase funds for 75 new residency programs. That would be at a variety of hospitals around the state. That's for $1,508,629. And last in this is section 17.12.4. It's a reduction in funds just due to the change in the FMAP percentage, and that for our budget yielded a reduction of $411,070. So that is the graduate medical education program for the board. I'm going to continue on into the Mercer School of Medicine. There are a series of adjustments going on in here, and what they are, the first two are reductions. It's 17.13.1. It's eliminate one-time matching funds to recognize private fundraising for scholarship for year 4 students committed to practicing primary care for 5 years in rural Georgia. That's $500,000. The next one is 17.13.2. It's eliminate one-time matching funds to recognize private fundraising for the expansion of the Valdosta campus. That's $75,000 reduction. And last but not least, it's section 17.13.3. Increase funds for the 6th year of a 7-year plan for the Mercer School of Medicine's medical school campus in Columbus, and that's an increase of $565,204. And that is the summary of the governor's recs for the Mercer School of Medicine. going to move on to the Morehouse School of Medicine, and that's section 17.14. There are no recommendations, so that will carry over, which will then bring me to the Physicians for Rural Areas program, and this is section 17.15.1. This is a non-dollar. This is a name change, so we call it the Physicians for Rural Areas, but in fact, there's dentists, physician assistants, nurse faculty, nurse practitioners in here, so we're just recognizing it to reflect a change in the program name to the Georgia Board of Healthcare Workforce Healthcare Practitioner Loan Repayment Program. And then line item 1715.2, what you'll see, it's a transfer of funds. So this is going to be originating out of the next program in our budget. So it's a $0 adjustment. Is we're just bringing $250,000 from in our undergraduate medical education, which we'll talk about in a moment, into this. So this allows us to administer all of our loan repayment programs from a singular bucket. It's really there for just administrative efficiencies, and that's it. So that is our Physicians for Rural Areas. And then we have our undergraduate medical education. This is the last, this is the sixth and final program within our budget, and this is that $250,000 that I was just mentioning a moment ago. It's line item 17.16.1. It's transfer funds from the nursing faculty loan repayment program from the Georgia Board of Healthcare Workforce Undergraduate Medical Education Program to the Georgia Board of Healthcare Workforce Physicians for Rural Areas Program to include all the loan repayment funds under the same program. So this is just a reclass of funds. And then really on the last sheet, I've got a summary. It has our original budget, it has the governor's recommendations, and that has a recommended FY26 budget. So with that, I'm glad to take any questions. I appreciate you at a minimum giving me a few minutes of your time to come on up here. So,
Are there any questions from members of the committee? I do have a quick question. Are midwives included in any of these loan repayments? We have a few midwifery classes going on.
I have to look at the rules. I want to be so. I believe if it's a nurse practitioner, an APRN, who applies under that, then yes. But there is nothing exclusive just to a midwife.
Okay, thank you. And let's see, Representative Buckner.
I'm just curious, should we? And I'm thinking that this would be important for a lot of these programs. Should we be aware of any potential federal dollars that you might get so that we just could, for planning purposes, know what, if anything, we need to be thinking, worrying, or doing?
Excellent question. We don't receive any federal dollars right now. And of course, if we were to obtain them in the future through grant writing or any other endeavor, then of course I'd be glad to keep you all apprised.
Thank you.
I don't see any other questions. Thank you.
Thank you.
Our next presenter will be the Department of Community Health. If you want the podium.
Sure. Yes, ma'am.
Thank you.
See, it's that last one. Yeah. There you go. All right. There we go. Thank you. Thank you, Madam Chair and members of the committee and everyone watching home. My name is Russell Carlson, Commissioner of Department of Community Health. It's an honor to be with you today for the governor's recommendations for the FY26 budget. I know I was here recently with the amended budget, and there are a few items that I've still included in here. I don't want to be duplicative, but in the spirit of being a takeaway resource, and especially with some of the enrollment figures, it helps to have that context on how we've gotten to some of these numbers for the 26. So I'll begin. Just as we always include, and we did, I believe, go through this during the amended presentation, we always like to start off every presentation with a little bit of a status check on how we've been able to implement, and in the event where we haven't been able to, but I'm proud that this past year we've been able to implement, execute, turn on, if you will, the initiatives passed by this body from the last legislative session. And I do always like to remind, even for those of you that follow the DCH board actions, a lot of these items, when they do require DCH board approval and ultimately CMS approval, when that approval comes, they're often retroactive to July 1, so those both providers and recipients, Medicaid members, SHPP members do get the benefits they're entitled to, even when it's in a retroactive fashion. But we're proud of the execution on being able to get your initiatives, your priorities from last session out into the field, if you will. And I always like to kind of just show, as far as the programmatic, just the big picture, where the proportionality of our spending by program, and obviously we'll go through these in more of a line item fashion, but this should be similar to years past. As I believe I said in amended presentations, we are between 97 and 98% benefits based as a department, programmatic in nature. So a lot of the funds we do receive are closely monitored and audited as far as staying for the purpose by which they were appropriated. So this past year, the year we're operating in now, I should say, you're looking at just over $5 million in state funds and over $20 billion in total funds, rather, along those program lines. And again, just for context, when you are so benefits-based, so programmatic-based, a lot of your spend, your projections will be tied to enrollment, how many beneficiaries we have. Obviously, utilization along different lines plays a big part of that, but by and large, it's driven by enrollment. And as I know y'all discussed hurricane relief on the floor today, you'll see some of that represented here, in that the DSNAP benefits took a fairly mandated priority during the aftermath of the storm. So we're very appreciative of the DFACS workers and the caseload that they have, that they had to shift from Medicaid eligibility to disaster SNAP. But thank you to the work you guys have done in alongside OPB with ARPA funds on allowing us kind of some staff augmentation that following redetermination and just the backlog coming out of that. We were able to reallocate resources, which allowed the DFACS workers to do their fairly mandated work on disaster SNAP, while our contractor support and eligibility was able to focus on Medicaid, and we were able to kind of hold as you can tell, a bit of a steady state when it came to that, where Medicaid eligibility did not come to a grinding halt. So we're very appreciative of the resources you gave us. And as you can see, the base trend moving forward as it pertains to enrollment, which again affects all the projections you have before you, we're getting back to somewhat of a steady state where the increases in enrollment are kind of tied to population growth. So the rocky ride of redeterminations has come to an end, and we're beginning to get back to what you can kind of expect on trends and population growth. Moving into the governor's recommendations themselves, we have several different items here. I would point to some. We'll go over these in some subsequent slides, but you'll see reductions in HFRD, which I can elaborate on. And again, a lot of the growth numbers that you see before you are related to enrollment. And here we'll go in a more of a line-by-line fashion. But again, much of this are either statewide changes or items related to growth or legislative initiatives. I'd ask, if you look at the first two lines under departmental administration, those are we're grateful for the support that the legislature gave us last year, and the governor's office and his budget allowing us to carry forward to stand up the PACE program that you guys approved both legislatively and via appropriations last year. It's an innovative program that a lot of other states have gotten into that is long-term care for that population, nursing home eligible level of care, 55 and older, but it allows us to maximize services with Medicare paying a little bit larger proportion of that, as most of those are dual eligibles. But it's an innovative program that has had success in other states. We're working with our partners at DOAS to release the procurement that would allow this to go out into the field. We have a lot of interested parties as far as providers through our town halls, and a lot of people when the procurement does go live, we think there'll be a lot of interest, and the competition will serve us all well. And those will be in several larger areas throughout the state. And we're looking forward to that going live. And this is the consulting support for those programs, actuaries for rate setting and consultings for standing up the provider network in those senses. And then the third line is something I know that's very important to all of us. The Katie Beckett program has been something that we are always trying to improve. The application process is pretty robust, and we're always trying to ask ourselves, how can we improve processes and business enhancements? We're doing several things on the technology side through case management systems that's improving that. But this is, we're very grateful for OPB providing for 3 additional actual caseworkers in that space. So we think some of the caseworker increases alongside the automation can hopefully provide relief to, yes, caseworkers, but also the families as that application process is. It's a big one, and we never lose sight of that. But that is matchable 75-25. That's why the dollar figure for those 3 caseworkers is as you see here. And then there's been a transfer there from on the lupus council there to the Department of Public Health, rather. And then under that, on the slide here before you, is a conversation that Commissioner Tanner and I have had for some time about always being open to realigning priorities. There are a lot of times in these braided agencies, if you will, where we're the payer, it's Medicaid, but DHS or DBHED or DPH is really the subject matter expert, and we always recognize that. So this is an instance where Commissioner Tanner and I, we have introduced legislation that will be moving through the process, and we stand ready to help answer questions. We're hopeful that and optimistic as far as getting that through. I think it's something that aligns the licenses involved or DATEPs, which you've heard of, drug abuse treatment education programs, narcotic treatment programs, adult mental health, and community living arrangements. Just some areas that DBHED really houses most of the subject matter expertise. And a lot of times, frankly, as us and the CMS kind of strings sometimes that come attached to things, we felt more often than not we were getting in the way. And I think it's a responsible realignment between our 2 agencies that both Commissioner Tanner and myself hope can yield better results for the providers and the members. One item that I do like to point out on the SHBP that you see before you, and we do have some SHBP slides on other matters, but the funds provided for independent pharmacists last session within the SHBP space, those were one-time funds per the caption. So that dispensing fee, we recognize, unless further actions taken, would expire. And that's something, in addition to being an actual line item before you, we think it's the right thing to do to just make everyone aware that those were one-time funds. And then there has been some, the next slide will speak to this and further. There's an SHPP matter that we want to bring to your attention that was included in the budget. Just some of the costs associated with the education side, active state employees and education, the educators. The programs are still one SHBP as far as benefits, but there are some differences in how they're funded. And so this allows for some, or calls for some increased funding from the school level, but not so much to pay for the quote-unquote cost of the plan as far as health care costs necessarily rising, which they are in line with inflation, but we've addressed that with premiums. But this is really more of long-term sustainability as far as the retiree community, and making sure that all retirees, whether you're retired from state active service, state employees, or the education community, to make sure that the plan has the coverage, long-term soundness to pay for a lot of the coverage on the retiree side. So that's what this plan is meant to address. And then some further, more on the growth per our larger programs. Again, most of this is just tied to enrollment. As you've seen, the age-blind disabled doesn't necessarily grow in size. Theirs is more of a growth in utilization, but the low-income Medicaid and some of the movement in Peach Care is aligned with just enrollment figures. Also, Peach Care and some of the limb population, there was changes made to continuous eligibility for children at the federal level, so that's changed some, we believe. One thing I would note, the FMAP was adjusted at the federal level in our favor, so the state received some savings there. But these in the bottom right corner, you'll see the total growth estimate of $280 million, a little bit over that, but again, we feel that it's largely due to our updated projections. And that's the end of my slides as it pertains to the actual numbers and items addressed in the budget, but we're always trying to stay current. Thank you for Morgan and House budget staff, always trying to make sure we're turning around estimates and projections for anything House members have an interest in. So anything I can help with, Madam Chair, members of the committee, I'm happy to do so.
Thank you for your presentation. We do have a question.
Number 25.
Okay, thank you.
Thank you, Madam Chair. Thank you for your presentation.
Yes, ma'am.
So, if I heard you correctly, you said that $20 billion in federal funds is part of what you're presenting to us today, right?
As far as some of the adjustments to FMAP, yes, ma'am. I think just some of those percentages as far as the federal state match changed to that effect.
So,
Oh no, you're talking about the total. You're talking about the total. Yes, ma'am. I apologize. The total funds for the entire department. I apologize.
So, in light of what's happening on our federal level, are we making any changes to how we plan?
So I'm glad. Very, very good question. Those are real-time conversations, to say the least. In fact, true story, the day that we were presenting to you for the amended budget was the day, if you recall, one of those kind of periods there where the transition at the federal level was just taking hold, and we, as I presented that meeting, I think I alluded to it, we had gotten word verbally that the Medicaid funds should be in a good place, but we hadn't quite gotten it on letterhead yet. So I'm proud to say that those assurances since then have been in place, and the Medicaid program itself is in a good position as far as delivering services here today. But to your point on what's moving forward, right now I can say through just our associations there and relationships there, both in Congress and some of the staff level and at CMS itself, we do have awareness of some, just as you do with some of the reporting, of some of the programs that may be scrutinized. And we feel it's our best thing we can do for you guys is to kind of internally war game and model out what those would look like. Right now, I do gather that Congress, will be moving into a reconciliation conversation on whatever they want to propose on into March, and we're trying to stay current on that. But we're trying to plan for pretty much anything. I had a conversation with the trade association just this morning, letting them know out of spirit of transparency that there's some programs that of interest to them that we, just as they have gathered, that are being, they're asking tough questions on some of these programs. So I think right now, the best thing we can do is all be transparent with one another about what we're hearing and how we might account for that. But yes, ma'am, we're tracking the possibility of some changes. But I do want to be clear too. Right now, as it stands, Medicaid is being funded and operated appropriately. So I don't want to send out any alarm as far as current day services.
Okay. If I may, Madam Chair, under redeterminations, that you said we've made it through that. So are there any recipients that never made it through the redeterminations? Or did we lose people or?
Well, no, I appreciate that. After the redeterminations were done, the enrollment figures did go down. So by that, I will say that from the height of the PHE, when none of the determinations were happening, to when redeterminations started, we kind of started getting steady state. The enrollment figures were down. I would say, and we have a robust amount of research because we were having to report these to CMS monthly. A lot of those were largely, let me say it this way, as redeterminations went forward, we got, along with DFACS, who is really leading the charge on this and did a great job. Like, we got better at doing this. Our ex parte, our automation approvals went up. The administrative denials continue to improve. And I think one thing that we just the volume of it left a backlog that we're all working through on just getting applications done in a timely manner. So there's still a lot of volume there. I'll never hide that fact. But as far as redeterminations itself, it was a challenging exercise. And it was never lost on us that real families were going through it. But it is something that month over month I think the data show we were able to improve, because I think we were just honest with ourselves on things we were doing well and things we weren't.
One last question, Madam Chair. I think it's Voices for Children who make a recommendation that we have continuous eligibility from 0 to 6 to make sure children get the healthy child checkups and whatnot. What are y'all looking at that?
Yes, ma'am. I'm familiar with some of those proposals. So I think something of note to demonstrate that I think a lot of people could appreciate the advocacy they were doing for the governor's Pathways program that is up for renewal. So we just finished our town halls and our public comment just the last couple of weeks. And for the renewal, the governor has already proposed to go in that renewal within the Pathways program for ages 0 to 6 for children, parents of children that are already on Medicaid, to provide a caregiver option for those parents, and then for the continuous eligibility from 0 to 6. That is something that we've always been mindful of and try to follow the data on as well as we can. I do think the continuous enrollment side help that CMS approved, to where even if your income does not change over the year, you will not have to renew for 12 months. In other words, on your anniversary date, if you're up for review every March, children under 19, you're only going to be reviewed every March. Even if your family circumstances are changing on income, they still give you those 12 months of continuous enrollment. So some of these policy movements have been moving in the right direction.
Thank you.
I don't see any other questions. So thank you very much for your presentation.
Thank you.
You offered some great information. Thank you.
Oh, thank you for having me.
Our next presenter will be our Department of Public Health. Please come forward. You can either be at the table or the podium, whichever you would like.
I'm not proud. I'd love to sit down.
I'm with you. Okay.
Thank you very much, and I'll try to be as efficient as my colleague Commissioner Carlson was, as well as demonstrate how well choreographed we are across our departments, because that was a word he used our last hearing, and I just love that because it really demonstrates how we work together. Why don't we go ahead and start with the statewide items? The governor's recommending common changes that you've heard about from other departments, not unique to us, and I think it's sufficient to say that these will be implemented in similar manners. But moving on to the next slide, slide 2, is the governor's budget recommendations. Some of these you saw in the last budget hearing, some will be new in this go-round. One is that efficiency transfer of funds from DCH, as Commissioner Carlson said, for the lupus, for the lupus research. We have existing contracts. We actually have telehealth work with Emory in the Albany district, and a longstanding partnership in this area, so it made a lot of sense to piggyback that into DPH. The Brain Health Awareness Campaign, again, a transfer from DHS. This is work also with Emory, where we have existing contracts with the Brain Health Center of Emory's and doing Alzheimer's work with our own team. And we are happy to take on these additional awareness campaign that had been in DHS. So the contract will just piggyback on. Last budget, this is a carryover from the governor's budget for this year. This is for the low THC registry cards. I see that Composite Board is here. They'll be talking later. We have really developed a great partnership with them on this, as well as have worked, thanks to your funding, to improve the management of that program as we've centralized operations, been able to quickly and efficiently get those cards out to people through the mail, raising the fee and going from 3 years to 5 years, and having a portal where the fee can be entered without having to come to a health department. And all those funds that go into that portal will then go into the Treasury, so it really is a it actually is a no-cost extension. So we really are proud of the work we've done to beef up that program, including getting accurate data, thanks to, again, to the epidemiologists that you funded last year. So this is a real good news story. And another good news story, which is a subject near and dear to several of your heart. And I want to say that several of you know more about newborn screening than I do. And several representatives on this committee have had a long history with newborn screening. I thought I knew everything I needed to know until early this morning. I looked it up and did not know that PKU was first tested in the state in 1968. I did not know that. So yes, we've done newborn screening for as long as I have been in practice, but it was relatively, I call that recent. I know you youngsters don't. I call that a recent program, and it was exciting to see now over 30 conditions and sickle cell, and other, and newborn hearing screening now added to this budget. So I think this is an exciting opportunity as we're adding now CRAB-A, which was on pilot. We've seen that we've been able to identify this condition. We've worked out the logistics of testing it in the laboratory and being able to work in partnership for follow-up. And so this, again, will become part of the profile as recommended by the federal and our state advisory committee, and the fee will be increased to accommodate that. So again, it's a no cost. And there's a lot of words to something that says yes and no budget item, but it was pretty exciting to me, who thought I knew a lot about this program, until I realized that there's so much more to know. And so I thank you all for your support for that. But now moving into something I'm really excited about are the maternal and child health programs. And several of you We're aware that in September, we had convened a meeting to pull together perinatal centers, other stakeholders, many in our team and others from around the state, as well as DCH, our longtime partner in the maternal and child health area, to talk about what do we need to do to improve maternal and child health outcomes. I know maternal mortality has been a challenge that we have been trying to address, but I cannot think about maternal mortality without also saying infant mortality is not where it needs to be in our state, and we need to look at that as a dyad, because a healthy mother is required to have a healthy baby. And so as we look at that, what were those things that we can do collectively with the system of care for our mothers and babies to improve perinatal outcomes? And out of that, and out of the recommendations of our meeting, as well as the Maternal Mortality Review Committee, have come a number of suggestions that I am very grateful to the governor to including in his budget and will be carrying forward. The first is expansion of the home visiting program. You've heard me talk about this before. This is something that is near and dear to my heart, having worked with home visitors in other areas and seeing the impact that they can have. I just happen to have, hot off the press, our new flyer, which I'll be happy to share with you. And as well as several of you on the committee will be getting in this recommendation as we expand new home visiting programs. In Chatham, there had not been one. There now will be one, as well as in Bibb County. There is a McVie program in Columbus, but even more importantly, you have a perinatal center, which I'll be getting to next. But we will pass this out to the as well as the summary of the impact of the home visiting program, which I passed out over at the Capitol in a lonely time over Christmas when I was the only one there passing these out, and I saw Madam Chairman and shared it with her. And I have some copies for you all as well if you're interested, because I think what has been remarkable is how much impact this program in such a short time has already had to save lives of mothers and babies. And this is the hope that we would have. And I really thank you for considering this expansion to some additional counties from 50 to 75. And finally, let me just talk about the perinatal centers, because this is something that isn't as perhaps easily understood, but I think for those of you, particularly in rural Georgia, you know how difficult it is to find specialty care, particularly if you're in rural Georgia. And I think this has been particularly true at a time in Georgia where we not only have hospitals that do not provide perinatal services, but that over the last decade, 15 hospitals have closed their labor and delivery services. And so we have a diminishing opportunity for care in rural Georgia. And recognizing that, we recognize that also that we've had a perinatal system that has been in place that we have tried to strengthen over the last several years, but that we, in partnership with my colleagues in DCH, recognize that we can actually improve those services and coordinate them better in a hub and spoke manner so that these centers can better serve all of rural Georgia in those perinatal center areas. And you can see if you live in the Atlanta area, there's many high-level hospitals that you can go to. But if you're in South Georgia, there is not. If you're an OBGYN, for example, practicing in Vidalia, it's a hypothetical, but imagine practicing in Vidalia, you have to go to Savannah send that high-risk pregnancy to Savannah for care. And that's just not acceptable. And there's 6 perinatal centers, one in Atlanta, but many high-level hospitals in Atlanta, but 5 for the rest of rural Georgia, including in Columbus, in Macon, in Augusta. And so recognizing in Savannah, of course, Albany, Phoebe Putney. So looking at these and building on these, we see that we have telehealth equipment in all of our health departments, that most of our health departments, we can use this equipment to transmit information to the perinatal centers, and with some additional funding to support increased services at those centers. So it is both maternal fetal medicine specialists as well as those, what we call itinerant workers, who are high-level technologists who can come out to the health department through telehealth to do things like EKGs in the field, can do sonograms of the fetus in the field, can do other checks, including blood pressure checks. And only then, if they need to be seen with hands-on in that center, arrange for their care and their transport. I've seen this in action. It is extraordinary to see. I was watching a fetal maternal medicine specialist here in Atlanta with someone in rural Alabama, and I could not believe what they were able to do in terms of having someone there do a sonogram and do a cardiogram and take care of this high-risk obstetrical patient. And we know what the leading causes of morbidity are among high-risk women. We know what some of these challenges are. We can staff those perinatal centers in this model to be able to provide that support through that telehealth service in the health department. And again, I credit this as a partnership because it's a small amount of funding, state funding, under $1 million, that will draw down more than matching federal dollars. And so I'd like to say we don't have billions of dollars like DCH has, but we really, I think, get a lot of bang for our buck in these programs that are working hard to protect the health of the public. And the final is our capital projects. This is not an area that I'm good at in terms of knowing what's the difference between a chiller and something else, but I will say that we only have 3 district offices, which is something else that surprised me. And these 3 district offices are aging, and these are renovations to these offices that have been recognized to be needed in Albany, Waycross, and Rome, plus our public health laboratories, both at Claremont and here in Decatur, as well as in Waycross. And so that's a total of a little over $1 million. And that, I think, is probably more time than I was allotted, but I appreciate your time. And I have, again, these publications, both about our home visiting program, as well as our report of the first years that demonstrate how much impact it's had in a very short period of time.
Thank you. That was very good information. You do have a question, Representative Buckner?
Thank you, Madam Chair. Can you rank the causes of the OB closures that you mentioned, the 15 hospitals that decided not to do that? Is it workforce shortage? Is it a change in the childbearing age population? Is it lack of payment for the services? Is it medical malpractice?
I would say it's all of the above.
Is there
And
a
of course,
ranking,
I'll defer to Dr. Burke, who used to be sitting here. He probably has fled, so that he won't be asked. But I think all of those things. When I have gone to meetings, and when we met with the perinatal centers, they said we can't hire, we don't have who's going to do telehealth. And risk that malpractice? Who's going to want to do that work? How can we bring someone into a rural area? So it's hard to hire, it's hard to maintain, and certainly these smaller hospitals that have few deliveries, particularly to offset the few number of deliveries with whatever that malpractice might be. And I think it's part of it is just financial. I think there's a great desire to do this. And the important thing to remember is just because you're no longer, saying you're doing deliveries and your labor and delivery service is closed, doesn't mean you're not going to end up doing a delivery in the emergency room or some other place, because that may be the closest hospital. And that is not what we want to see. What we want to do is to encourage women to be able to get the services if needed, particularly high risk, who have high risk conditions, whether it be hypertension, diabetes, HIV, and then we can help them through this work with the centers, and then transport them at a more appropriate time and help them with the transport.
May I follow up with one more?
Yes, go ahead.
I don't know how to ask this, and if it's going to put you in a bad spot, you can say you'd rather not answer. But I remember working in public health, we relied very heavily on the Centers for Disease Control. And I'm really concerned about some of those programs that are being totally abolished. And do you foresee there being a negative impact of the changes at CDC to public health is what I really want to know. Or how bad do you?
This is not a trick question. I mean, I think for someone who's been in public health as long as I have, I mean, public health isn't just a federal system, and then there's a state system, and then there's a local public health. We're a system. And we not only work in partnership across all these systems. I mean, newborn hearing hearing and screening is an example of that, because there's committees with much smarter people than me who sit on these committees. I mean, when we look to the federal government for guidance, but we also work across, I think there is concern, and I hope that the loss of people from the hierarchy will not impact that kind of system that has been in play for so many years, because it has made such a difference across the board in all these programs, including the maternal child health programs. But I can't say, because I don't know how this is all going to unfold. We're all watching it as you are.
Chairman Hawkins, you have a question?
Yeah, I made a promise to Dr. Marshall I would say something. He was going to try to be here today. With any of your remaining funding, I know you all have a lot, if you could put some toward the Office of Cardiac Care, make those cardiologists awful happy.
No, and he should be happy that we're also looking at this. We're calling this a cardio OB, even though it's maternal fetal medicine, because we recognize the high impact that cardiac care will have in improving the health of mothers.
Thank you.
And babies, by extension. So.
Representative Hughley, you have a question?
Thank you, Madam Chair. I'm looking at your slide number 6, and in that Augusta area, how far are people having to go?
No, it's a long ways, and I really credit Chad Ray and his team in Augusta, who really developed this hub and spoke model, and when we followed his lead, we were able to build that extension, because it's a long ways. That example of Vidalia to Savannah was how I testified to Chairman Tillery, because that's his wife practicing in Vidalia. I mean, I think it doesn't hit home until you realize how far this is, and many, of our patients don't have a means to go that far, let alone can travel, 800 miles for care. No, you are absolutely accurate, and I think we can do the best we can to strengthen the system to better serve the patients we're trying to serve. And I'm very excited that the governor has gone this route, and we look forward to building further with your support.
Thank you, Madam Chair.
Representative Bennett?
Thank you, Madam Chair, and thank you, Commissioner. I always enjoy listening to your presentations, and I'm excited about the expansion and the need to expand. However, my question, Madam Chair, I will waive and speak to the Commissioner and then come back with the question.
All right, thank you.
Thank you.
I don't see any other questions. We appreciate your information and sharing this with us. We all have this concern, particularly when you see it on the maps. We need to continue to improve on that. Thank you.
Absolutely. And build on a good system we have and make it better.
Thank you very much.
No, thank you.
All right. Our next presenter will be the Georgia Board of Dentistry and Georgia Board of Pharmacy. If you would come, do you want to come to the table or the podium?
I'm the Executive Director for the Georgia Board of Dentistry and the Georgia State Board of Pharmacy. With me this afternoon is Dr. Michael Knight, our Board President for the Board of Dentistry, and our Deputy Director Stacy Altman, who is the Board's Chief Investigator and the head of the Investigations and Compliance Unit. We're honored to be here this afternoon and that you've given us the time to talk about the board's needs and for the coming year. We can go to just a couple weeks ago, the House passed HB 67, which included a total of $500,563 for the acquisition of new licensing software for dentistry and pharmacy. Originally, the governor's proposed budget had allocated a little less for this project due to the complexity of the history of this project, which led to double counting of some of dentistry's retained revenue, and this House added that difference back, and we're extremely grateful for that. And that ties into the governor's proposed budget for FY26, which has provided $75,000 to each board in lines 17.1 and 17.3. This combined $150,000 makes up, or is the difference between what the boards are currently paying for their My License Office subscription and the increased subscription cost for the Evoke software to which the boards will be moving over the next year. That concludes the governor's proposed budget, but unfortunately it does not conclude the board's needs. Before we continue, it will be important to understand the unique administrative structure of the boards of dentistry and boards of pharmacy. As noted on this slide, the boards are set up in a unique way that they're separate entities, separate budgets, separate legal authority, but they share a single staff. There's much crossover, especially in customer service and licensing techs between the boards, where they serve both boards even though they are paid under the budget of one or the other board. And this is our current organizational structure. I've included this chart and various iterations of it in this presentation as it directly relates to an ongoing reorganization effort that we began last year at the request of DCH. They identified our organization structure as being too flat, where every employee either reported to one manager who had 9 direct reports or the executive director. And so it was advised that the board adopt a more vertically stratified structure, and so we have been in an ongoing process to achieve that goal. And lastly, before moving on to the individual boards' presentations, I wanted to show this data. Since the board separated from the Secretary of State's office in 2013, the board's combined budgets have added up to less than or approximately $2 million per fiscal year. In that same time, the boards have generated more than 2 times that input each year. In short, the boards are revenue generators for the state far more than their budget footprint, which brings us directly to the Board of Dentistry. You can go ahead to the next slide. The Board of Dentistry is in danger of failing its duty to regulate the practice of dentistry in the state of Georgia. And I understand that's a grave statement, but unfortunately it is the state that the board finds itself in. Over the last 10 years, the board has seen a volume of complaints that has risen each year and which has been beyond the board's capacity to process and resolve for many years. As a result, the board has a very low case closure rate, which is detailed on the next slide, has developed a large backlog of cases and has an average case resolution time of 18 to 24 months. For comparison, you'll hear Director Michael Karnbach of the Georgia Drugs and Narcotics momentarily, who will show you that the cases coming to the Board of Pharmacy average about 80 days for resolution. We believe the primary driving factor for these deficiencies is not a lack of effort or desire to investigate the complaints coming to the board, but rather a lack of manpower. In fact, the entire investigative capacity of the Georgia Board of Dentistry is right here. We have one investigator to cover the entire state. Director Altman has the impossible task of managing, conducting, and processing every investigation that comes to the board from all over the state. In September, we were able to get him help on the administrative side, but even with a new compliance investigator, the board's investigative unit remains unable to handle its responsibilities. At present, the board lacks the funding to provide Director Altman with the support he needs to meet the task that he is presented with in the form of additional personnel, equipment, and training. Additionally, the board's existing personnel are at risk from other state agencies with similar roles in regulating professions in Georgia. Last year alone, the board lost 3 senior employees representing a wealth of institutional knowledge to other state licensing boards, and almost lost another whom we were able to keep only by swiftly matching the offer. Accordingly, the board is also requesting an increase of funding to retain the board's licensing experts. As I discussed earlier, a low case closure rate. The board's case closure rate for FY 2024 is just 3.1%, and over the last 3 years is only 28.3%. And the board presently has a backlog of over 2,000 cases. Annual complaint volume exceeds the investigative unit's capacity every year to process and resolve those complaints, which means the backlog will continue to grow. While we haven't been able to provide additional manpower, the board has implemented several steps to attempt to become more efficient, more responsive, more nimble. The Board of Pharmacy has a different process for processing complaints, which allows for a filtering of complaints before investigative resources are invested in that process. We have implemented that, or are in the process of implementing that, so that we focus the our limited investigative resources where they're most needed. And we are in the process of bifurcating the investigative and administrative tasking between our 2 investigative unit employees, so that our post-certified investigator can focus his investigative expertise on the investigative aspect of cases, whereas the administrative employee can focus on the admin side of those cases. In terms of the increasing complaint volume, the board has seen, since 2014, the board has seen an increase in cases of 16.9%, of complaints received by the board of 16.9% year to year. The board received 806 complaints in FY '24. And if that trend holds, we expect to receive over 930 complaints this year. To underscore that number, we have resolved only 3.1% of the 806 complaints received last year. Therefore, to shore up the board's investigative unit, the board is requesting 15 new administrative positions. The cost of these positions is $1,171,040.48. And this is based off the median salary for each of the job codes. This request encompasses 6 post-certified positions, 5 criminal investigators and 1 supervisor, as well as 6 non-certified positions composed of 5 compliance investigators and 1 supervisor. The board intends to build out the investigative unit with criminal and compliance investigators operating in tandem to work cases splitting administrative and investigative tasks. The board developed this formula from recent experience with a second investigator. In 2023, the board hired a second investigator and had a second investigator for about 10 months. During that time, we realized that adding a second investigator did increase the number of complaints we could investigate, but it was an inefficient way to approach the task, or to approach the problem, in that it did not alleviate the administrative burden on the investigators. And so we had post-certified investigative staff who were spending a significant amount of time sending subpoenas, processing complaints, receiving medical records, and it did not allow our investigative experts to best spend their time. Following the departure of the second investigator, we reclassified this position to a non-certified position, and that was in September 2024. And by doing that, we were able to hire a dental hygienist who had dental experience. And so we were able, by making that position non-certified, we were able to add dental industry experience, which previously the investigative unit lacked. And we were able to make use of that expertise. And given the benefits that we've already realized, the board intends to continue to build out the investigative unit in a 2-by-2 manner, pairing the compliance and criminal investigators. We can move past that slide. Additionally, as shown here, the Board of Dentistry's investigative unit currently carries a caseload 2 to 5 times higher than that of other comparable healthcare regulatory boards. The addition of 12 positions to the board's investigative unit will bring the dental board in line with those boards. And shown here is the Georgia Drugs and Narcotics Agency, which is the investigative unit for the Georgia Board of Pharmacy, and then also the Georgia Composite Medical Board. The benefit of additional investigative personnel is that it would allow us to bring the investigator caseload to approximately 335 backlog cases per year and 160 new cases per year, which would allow the board to work down the backlog and absorb the rising complaint load that it is receiving year after year. It'll also decrease case resolution times and improve the perception of strength and reliability among the public and licensees. One thing I hear from Director Altman frequently is that people who have members of the public who have filed complaints with the board wait a year and a half, 2 years for a resolution, and they have developed the opinion of the board that it exists not for regulating the dental industry, but rather to protect the dental industry by dalliance. And we desperately seek to rehabilitate that image and to serve our purpose of regulating the dental industry and ensuring safe practice of dentistry in the state of Georgia. Additional compliance personnel will also allow the board to pursue multiple large investigations at once, which it is currently not able to do. The benefit of additional compliance personnel, compliance analysts functioning in tandem with criminal investigators, will allow the criminal investigators, as I've already said, to our post-certified investigative experts will be able to focus on investigative tasks while compliance personnel are able to focus on the administrative tasks. Additionally, compliance analysts will monitor licensee compliance with board orders. Currently, compliance with orders from the Board of Dentistry is not something that the board has the manpower to well monitor. And it has led to a situation where essentially compliance with board orders is on an honor system, and it is not a tenable situation. As I explained before, in March of last year, DCH identified that the board's administrative structure was too flat. This structure shows the necessity, in order to comply with DCH's request, we have included compliance and criminal investigator supervisor personnel, which will provide an intermediate level of management between the director and the unit. Additionally, as I alluded to earlier, the board is requesting an increase of annual funding to support pay raises for the board's licensing analysts. Currently, our licensing analysts are paid below the median for their job code and are subject to being pulled by other state agencies. I have two job postings here, one from the Office of the Commissioner of Insurance and Safety Fire with a licensing tech advertised at $47,500, and then from the Georgia Professional Engineers and Land Surveyors Board for a licensing analyst with a salary of $52,000. The board is currently not able to compete with these other state agencies, and we risk losing our our licensing subject matter experts as a result. We can move on because that one we just covered. Additionally, in order to support the requested build-out of the board's investigative unit, the board requests annual funding to provide law enforcement and dental industry training to its investigative staff and to fund the board's subscription to the CLEAR investigative software. CLEAR is an investigative tool used in the board's investigations. And finally, the board also requests a one-time appropriation to support the board's build-out of the investigative unit for law enforcement equipment for the board's criminal investigators. As a note to this request, the board intends that this request be scaled to the number of criminal investigator positions that may be funded by the House, such that if less than six positions are funded, we would request that it be adjusted downward accordingly. Madam Chair, that completes the Georgia Board of Dentistry. Is now a good time for questions, or should
Yes,
I complete?
does anyone have questions? I have a question. I kind of want to know, what kind of complaints are you getting? That's my big thing. I mean, what, are they licensing? Somebody doesn't have a license? Have they charged too much? I mean, what are you getting? I just have never had a problem with my dentist, so I'm trying to figure out.
Everything from the kind of complaints you just described. We do receive reports of unlicensed practice. We receive malpractice type reports where there's a standard of care issue. Anything?
So the complaints that we receive range from treatment related to the unlicensed practice of dentistry to patients that have to go to the ER to death cases. So everything that falls within the board's rules and laws, we get complaints on. The amount of those complaints just depends on the year. So a year could be treatment related. The last several years have been unlicensed practice. So that has been the thing that we have fought for the last couple of years.
Do you have multiple complaints about the same dentists?
We do.
Okay. You do have some questions. Let's see.
That's me.
Okay, go ahead.
Well, thank you, Madam Chair. That was my first question, the kinds of complaints. The other question that I would have is are the complaints all over the state? Are they concentrated in particular areas of the state? Because I haven't had a problem with my dentist either, but I've never heard any constituents with complaints about their dentist. So where is this happening in the state?
We receive more complaints, obviously, where there are greater centers of population, but we do receive complaints from all over the state.
Representative Siebel, you have a question?
I do. Investigator, I'm sorry, didn't get your name.
Stacy Altman.
Stacy,
Yes, sir.
thank you for what you do. I'm sorry that we put you in a position to be the only investigator to investigate all these complaints, but
Thank you.
thank you for what you do.
You're welcome.
So my question was, how long does it take on average to investigate and close a case?
So depending on the type of case, so currently it takes nine minutes to enter the complaint into the system when it's received. At that point, it's reviewed to determine if it's within the board's authority. If it is, we start issuing everything that we need to issue to get records, patient statements, doctor statements, whatever. If they comply, I can get that within 30 to 40, 45 days, if they comply. But there's nothing that requires them to comply with the board when they issue a subpoena. So if everything complies and everything goes through as scheduled, I can get a complaint and close it out within 90 to 120 days. If I have to go out and actually track down everything, example, I have to go to St. Mary's, Georgia for one case. That's a 2-day ordeal just to get there and back to get records.
So, and you're a post-certified
Yes, sir.
officer? And what additional training above and beyond a post-certified officer would someone have to?
So in this, there are certain things that we can do. We can take that aren't dentistry or dental hygiene require that license. So like recently, last year, I went to infection control training for infection control. I'm about to go through coding training to get trained on coding when I look at that. There are other trainings that we can take that are just standard everyday CE type courses that we can take to learn about the industry.
So what I'm getting at is because you got quite a backlog here, and I don't think the number of personnel that you've got in here is going to be able to keep up with the caseload and fix the backlog. So my question is, with the state police around the state, is there an opportunity to put together a task force to try to reduce this backlog while we work on fixing another problem?
Absolutely, I'm sure there is, especially the unlicensed practice of dentistry. That is
Okay.
something that would be of great help.
I know we're getting way beyond budgetary issues here, but there's got to be a solution to reduce this backlog as we figure out how to fix the problem. And I just hope that
And
we
as
can.
part of that process, or one of the things that we've started doing is I've taken a specific year's logs or of cases, and I'm working with the committee within the board to go through those in this new process to see what can be filtered out and what can't be.
Yeah. Do we suspend license while we pending investigation?
No, sir.
No.
Okay. That's all I have. Thank you.
Thank you. I have a follow-up question. Do you have what I would call like a dental consultant? If you have a question, was this the appropriate treatment? Do you get that far into it? Do you have somebody you can call on?
Yes, sir.
Okay.
So normally the process goes, the investigative committee will investigate. All this information is given to them. So they, the dentists that are on that committee with me, they are the ones that look at the case to determine if there's something that needs to move forward with action against the licensee.
Okay, thank you. I don't see any more questions. If you want to go with your next section.
And mercifully, the State Board of Pharmacy's presentation is not quite as long. The State Board of Pharmacy is requesting an annual funding increase of $233,136 to create positions in the board's licensing unit. Currently, the Board of Pharmacy is meeting its advertised licensure times, but it is not doing so in a sustainable way. Our staff routinely work nights and weekends just to get the job done, and we're blessed to have the staff that we have, in the sense that they have a work to the task, not to the clock mentality. And that has unfortunately led to a norm of working extended hours just to meet the board, meet the board's licensing metrics. And the board is only meeting those metrics because the staff are overworking. The licensing unit for the board is currently tasked beyond capacity, and there is no capacity to absorb new licenses. And at this point, the question is not only at what point will they burn out, but it's not a question of if, but when. And so the board seeks to reduce that analyst caseload by about 20%. Currently, analysts, with 5 analysts, the current analyst caseload per year is about 7,300 cases, and that's both new applications and renewals. A 20%, approximately 20% reduction would see that reduced to about 6,100 cases. And we see the ideal as about 6,000 to 6,500 applications per year processed by each analyst. The addition of a 6th analyst would put that analyst caseload in the desired range. Additionally, for the same reasons as were discussed under the Board of Dentistry, we're requesting the addition of a licensing supervisor who would serve as who would create the desired verticality in our unit, in its structure, and also reduce the number of employee direct reports. The position would also act as a second level of referral for public inquiries to licensing for both dentistry and pharmacy. And currently, no such second level of referral exists, and our director of licensing, in addition to her other duties, is filling that role. Delegation of this duty to an intermediate supervisor will increase our unit efficiency. Additionally, the board currently operates with 3 customer service personnel, and we routinely receive complaints that it is impossible to contact the board by phone, and so we are requesting funding of an additional customer service representative. Currently, the board misses close to 1,000 calls a week. That can be much higher depending on how close we are to renewal. And the board seeks to provide better accessibility to the public by increasing the available personnel to whom calls can roll when existing staff are occupied. And this slide shows the organization structure which would exist with the new supervisor and the addition of a new analyst, as well as the addition of of customer service personnel. And lastly, I have to apologize for this slide because this is obviously not the Board of Dentistry. And the position numbers should be 1 instead of 2. But the Board of Pharmacy is requesting that on identical grounds to that of the Board of Dentistry to provide an annual funding increase for pay raises with the same goal of retaining the board's existing licensing experts, which again we face significant risk of losing to even other state agencies and even the private sector. And that's it. I thank you for
that presentation. I don't see any questions on this segment of it. We appreciate your information and input. Thank you very much.
Thank you.
Our next presenter will be the Georgia Medical Composite Board.
Hey everyone. Moving a little slow. I had the tornado come through our area this Sunday, so if you see me babbling, please stop me. Lack of sleep, and I didn't know my soul could hurt from running a chainsaw, but we're here, and we appreciate the opportunity to come to you all and give you some information on the medical board and some of the needs and some of the things that y'all have graciously given us and what we've done with it. With me is Roderick Harper. He is our CFO, so he put together a lot of this stuff for us, so we appreciate what he's done. So we're going to move through some of these slides pretty quickly. In your packet, there are some stats that we're going to briefly go over, but if you have time, you can please peruse and ask questions if you have them. So the organizational chart that's up there now, I think that's slide 4, just gives you a breakdown of the medical board and kind of what personnel that we have. The next slide, number 5, is some statistics that I want to share with you. So we license approximately 66,135 professionals in a range from physicians down to genetic counselors. And this year, as of February 13, 2025, we have a total increase of 1,068 licensees from last year. So we're on a trajectory of adding quite a bit of licensees since I last saw you. So hopefully that will continue so that we can hit the marks of these professions here in Georgia. So the APRN protocol agreements aren't licenses. That's on the last stat. That's 21,726. That's a protocol we look at for prescribing of an APRN. We review those and process those, but those aren't licenses. They're just protocols that we review, make sure everything's there. So that's a lot that we've done since February 13th as far as the protocols go. I'm sorry, since July 24 as far as the protocols go. So I wanted to add that in to let you know we also review those. So just like our friends at the Board of Dentistry and Pharmacy, we do compliance and investigations as well. So our complaints for fiscal year 24 were 1,836, and we've closed a good number of those. There were some left over that we're working through now. So they'll come into fiscal year 25. As of now, since July of 24, we have 1,371 complaints. Number of active assigned are 690. And then if you look down, average compliance specialist caseload is 172. That's still large to give one person to work 172 cases. And we're trying to triage them down so that it's a little bit less, but that's still a work in progress. But that's still a large number, with our compliance specialist being, let's see, on the org chart it was there. So we have 5 full-time and 1 temp, which we were gracious enough to get 2 of them last year, which has helped with the process. So with those numbers, if you go down to the number of compliance cases on the same slide, medical director, so we hire a contract with medical directors to do our peer reviews on a lot of the complaints that come in, patient care. We have increased that from last fiscal year to this fiscal year by a tremendous number. So medical directors have about 197 complaints that they're looking at. And then in peer review, these are peer reviewers that we contract with to look at patient care issues. It's 146. That's went up, and we hope that it will continue to go up so that we can meet the needs of the ones that are complaining and need that help. So fiscal year 24, I won't harp on this slide, but shows we collected $7,898,000, submitted to the Treasury, and our budget was $3,151,000. So if you can need to peruse through that, it kind of shows where our budget was. So fiscal year 25, we were actually given additional funds to take care of a lot of the things that were lacking that we needed to do. So we appreciate that. We were able to hire a tremendous amount of personnel as well as get things updated as far as our technology goes, which I'll get into in just a bit. So we'll move on from that. So with that budget that was given last year, we were able to do a lot of things, which I won't go through each of them, but you'll have a list of things that we were able to accomplish. What we asked for, we've put into place. So we're moving forward with everything that we've asked for and that we promised to do. So we're moving forward with that. And we've also signed a contract with our new licensing database that was funded last year for us. So we appreciate that. That will help in licensing medical professionals quicker and be able to communicate a lot better. So House Bill 68, which is what the governor's office has presented, it shows that our projected budget is $4,039,035, and that removes the one-time funding that we received for our database system and vehicles for our investigators, because they did not have vehicles that were functional. So we appreciate that, and we've been able to utilize those funds for those positions that we asked for. So get down to the brass tacks of things and kind of our assessment of the year and where we're at and what we need. So much like our counterparts at the other boards, we're still in need of some compliance personnel that handle those cases, that triage those complaints that come in so that we're getting them done in a quicker manner. So we're asking for 4 compliance inspectors. Now these inspectors are different from compliance specialists, as these inspectors will go out to our licensed entities and do inspections to meet compliance needs. So there'll be field inspectors that'll be out in the field handling those things, but they'll also be doing compliance investigations that come in. So there'll be a multi-role position. They'll also help with licensing issues. So they'll have different tasks up under that, but I still believe we need some compliance inspectors to be able to help out. So we're asking for 4 at $368,752, and then we still need some licensed techs. So we're looking to hire 2 additional licensed techs or have that funded at $145,824. That'll be $43,500 is going to be their salary. And then, as you see with all of our compliance cases that were in those stats, we also need legal. And right now, we only have our deputy executive director, that's our legal officer, and she has a lot of work after board meetings to be able to handle a lot of these compliance issues that come up. So we're asking for a paralegal to be able to continue that and hopefully get that backlog done of things that happen after the board meetings. And so that's a total of $590,138 is our ask for this year to meet those needs. And it's also, in a way, the $572,993 that's the one-time funding that's being taken off, that will accomplish what we need to move into this next year to meet the goals that we've set forth and hopefully get things on the right track. So hope it wasn't too quick, but I was trying to get it clear and concise, but you do have the slides if there's any questions. I'm more than happy to answer them.
Thank you very much for that presentation. It was quite thorough. Are there any questions? I don't see any questions. Thank you very much for your presentation.
Well, thank y'all.
Next up will be the Georgia Drug and Narcotics Agency.
Okay, try to get up on the chair. Thank you.
Good morning, Madam Chair, or good afternoon, I guess, evening, almost at this point. Good morning, committee members. My name is Michael Carmbach. I'm the director for the Georgia Drugs and Narcotics Agency.
Could you get to the mic? Thank you.
There we go. My name is Michael Carmack. I'm the director of the Georgia Drugs and Narcotics Agency. Thank you for giving us the opportunity to speak today. My presentation will be short and sweet as well, but I believe it's a good opportunity for us to show how our agency is providing for all the citizens throughout the state. We are, like E.D. Joyner said earlier, we are the investigative arm, the enforcement arm for the Georgia Board of Pharmacy. So we have three primary objectives at the agency. We inspect, we investigate, and we educate. We inspect all registrants throughout the state, so we have the unique ability in our agency. All of our post-certified law enforcement officers are pharmacists first, so they come onto the agency, we hire pharmacists, and then we send them through the academy. So when we're out inspecting a pharmacy, we are checking prescriptions, we are looking at a pharmacy as a pharmacist, colleague to colleague, if you will, evaluating that to make sure that the patients are getting the care that they deserve. We have an on-site expert basically at every inspection. When it moves to an investigation, it's the same thing. We investigate all the complaints for the board. The board office triages, the office staff triages, as Mr. Joyner explained. They triage those complaints, they send them to our office, and then we send our investigators out in the field to conduct those investigations. We also educate. The healthcare professionals, law enforcement, and the public in various capacities, not just through inspections, but through speaking as well. We're a small agency. We have 19 positions, 18 employees. Right now we have one open position. We have myself, the deputy director. We made a couple of changes as well this year. We were a lot of people in the field answering to one person, and as DCH has asked a lot of the agencies, we moved to supervisors in the field. That way we didn't have a lot of people reporting to one. We have one supervisor overseeing 5 agents, and we have 2 of those in the field. We also have our office business operations manager who oversees the office staff. Just a quick glance, you can see how we break up the state through the territories. Everybody in the agency, all the agents in the field have an area that they're responsible for. This is based off geography or density of the pharmacies in that area. Fulton County obviously has a lot, so we have one agent that has Fulton County, and some agents in the south have 20 counties, but they actually have the same number of pharmacies, believe it or not. The map on the other side, there's a supervisor regions. Like I said, each supervisor has an area. That's not geographically half, but it's density half if we can consider pharmacies, so that's how we break it up. This doesn't represent every pharmacy in the state, but it does give a good representation of where the pharmacies are mostly throughout the state. So that kind of references back to the one previously where I said it's not geographically split, But we see there are all the pharmacy types here, and they're spread out through the state highlighted there, so we can see. I believe one of the other questions earlier was where do we see complaints? Obviously, this is where we see complaints. Where pharmacies are is where we receive our complaints as well. The pharmacy licenses, the pharmacy board licenses a lot of different license types. We investigate all of these. Retail pharmacy represents the largest at 2,200. We are boots on the ground. We darken the doorway of every pharmacy in this state, of every facility that has drugs legally. We darken that doorway. We inspect that facility. We educate those people, and we make sure that that those prescriptions are being filled correctly. Not only in this state, but there are non-resident pharmacies as well. So people shipping into our state, we don't physically go to those locations to do the inspections. Obviously, that doesn't make sense. But we do conduct those investigations as well. So if a mail-order pharmacy misfills a prescription to one of our Georgia citizens, they file a complaint with the board, we're going to investigate that as well. So that's another thing that's covered by our jurisdiction. We can see an overview of our investigations over the last 13 years in inspections. The blue represents inspections. Obviously, we see a trend upward as personnel have increased, inspections have increased. Inspections move up. That's something we can control. Investigations are challenging to control. Obviously, we can't control the number of complaints that come in, but we are starting to see a positive influence for the first time in a long time as our inspections are increasing, as I talked about our education and all the things that go with that. As the inspections increase, I think we're going to start to see, or we're already starting to see, a plateau of investigations. So the more we're in these pharmacies, the more we educate. Maybe it's a deterrence, but I think 95 to 98% of all healthcare practitioners want to do the right thing the right way. If we just show them how, then they're going to do that. So I think we're going to decrease investigations, which is a positive all the way around. Some investigation highlights over the last 4 years. These are the total number of investigations that we received. So last year we had 536 that we investigated completely. 215 of those were presented to the board. So not all of our complaints go back to the board. Every complaint that comes through the board comes to us. So if a citizen files a complaint with the board, that comes to us. We investigate it. We bring 100% of those back. But if we find an investigation or a violation on our own, or somebody complains, like a great example is a pharmacy has to report a drug loss. When they lose drugs, they have to report that, but they may not have known where the drug went. There's no evidence to that, to say who did it. That's not something that would go back to the board. That's something we investigate but would not bring back. So we have about 40% of the investigations that we investigate actually go to the board. They decide on what happens from there. They take the action. And our days to close investigations are about 80 days for all of our investigations. So we don't keep things open very long. It's not represented here, but when somebody files a complaint with the board and it comes to us, within 30 days or less, we've reached out to that complainant, had that first contact in person with them, and moved the investigation forward from there. So within 80 days, we're closing all of our investigations. For our inspections, there are about 3,800 facilities in the state of Georgia. In the last 12 months, we've inspected 65% of them. In the last 24 months, we've inspected 95%. So they're on different rotation cycles on how often we inspect them, but about every 2 years, we inspect every single facility in the state. So that's something we're very proud of. We'd love to have our numbers better. I'd love to say 95% in 12 months, but we've got to have goals, right? So that's where we are, but I'm very proud of that number. We see our appropriations here, our current appropriations. We are a lean agency when it comes to everything but personal services. So our people, that represents the largest bulk of our budget. We are responsible. We are, it's not a huge budget, but we are very proud of it, and this is how we currently are. I'll kind of break down a little bit more here. This year, it's pretty clean for us. I was appointed in December of this year, so haven't really had the time to put together the things that we want to ask for, but that'll probably come next year. So we'll do that in a responsible way. But for right now, no adjustments in amended, and in 26, the only thing we had was the DOAS insurance programs. A couple pieces from last year that I did want to report back on. We had a $21,000 enhancement for our database. Our database is still an ongoing process with us. We received the money for that 2 years ago in full. The creation of that database over the last 12 months has been great. We tried to roll it out a couple months ago. We had to pull it back for a couple of technical issues, but we're hoping to have that implemented fully here in just a couple of weeks. We'll have it testing and fully in a couple of months. $35,000 last year for tablets. So when our agents are doing inspections and investigations out in the field, you can't carry a big bulky laptop when you're walking around a 10,000 or 100,000 square foot facility. That doesn't really work well. So the tablets have been a blessing. They're already out in the field. We have leased them responsibly, and they are working very well. So we greatly appreciate that. A couple other pieces of things that will kind of blend in for next year, I suppose, but we were asked to use existing funds for a few things this year to digitize our records, which I'll talk about in just a second. We were able to replenish our body armor with existing funds. Remember, body armor expires every 5 years, and it is not cheap, so we were able to do that, so we're thankful for that, and we are still working to get our drugs disposed and other evidence. We were on a litigation hold for the opioid litigation that was just released recently, so we could not destroy anything, and a lot of our evidence, obviously prescriptions, paper, and all that, so we had to hold those, so we're still moving forward on that. Future focus, so the things we'll be looking for over the next 12 months, we do want to put an emphasis on education. We're doing a great job with investigating and a great job with inspections. We want to go back to that education piece like we used to before, so we are going to focus on that, getting back out in the public, getting back out to law enforcement and healthcare professionals in different ways. We need to evaluate our legal services. We currently don't have legal services in-house, and that's challenging, so that is something we're looking at, a responsible way to do that. I'm not sure if that'll require a full-time position or a part-time position or something, but we'll bring that back to the table next year when we're ready to have something solid on that. And then we need to continue our digitization. We're moving to a paperless system, like I think that's just the way a lot of people have operated for a number of years, and in a lot of ways we were still paper for a long time. So we've got a backlog of paper. We're working with archives on a responsible way to do that according to the state's retention schedules, but that is something that we're going to evaluate as well and see what our future needs may be for that. But that is all I have, subject to your questions.
Thank you very much. That was very thorough. Are there any questions from the committee? I don't see any. Thank you very much for your presentation.
Thank you.
And our next agency would be the Trauma Care Network.
Last but not least, I'm going to be very brief because I know I'm standing between you and the door. Oops. My name is Liz Atkins. I serve as the Executive Director for the Georgia Trauma Commission. Just going to give you a brief overview here. The Trauma Commission has been around since '07. It's a 9-member commission. I have 4 other staff besides myself, so we're very small. I have my Finance Operations Officer with us today, Katie Hamilton. We essentially are the accountability mechanism across the system. We oversee development, quality outcomes, and the distribution of funding. And you can see our chairman, Commission Chairman Ashley, presented a lot of this to you all last year, but it just shows the work that's been done since the inception of the commission. And you can see in the gray areas that's access to level 1 to level 4 trauma care. The lighter shade gray is actually level 4 trauma care. That's differentiated because level 1, 2, and 3, you actually have access to a trauma surgeon as well as an orthopedic surgeon. What differentiates really 1 and 2 is they have the full complement of specialties. So you can see we still have some gaps in Southeast Georgia. Most of those gains are probably going to be made with the level 4 centers because there's not a lot of those surgical subspecialties. You've heard a lot of other agencies talk about challenges with specialty care in the rural areas. Also, Dr. Ashley talked about where we were in terms of mortality, where in the beginning we were about 16% above or worse than the national average, and now we're 6% below. It's not just about surviving for us, though. It's about thriving, so we're investing a lot in our quality collaborative to make sure that we're achieving optimal outcomes and reducing harm events in the hospitals. So we have a very robust statewide risk-adjusted benchmarking program. This is our, I call it proposed budget. Our budgetary categories, if you will, don't change much from year to year. So the commission will vote on the final allocation, which again probably won't change much, just subject to the legislative approval. And then the only, besides the super speeder funds that you see, were line 3814.2 and 3 is the elimination. I think that was originally set up as a multi-year for the EMS pilot project that did not pass. The legislation didn't pass. There was a funding item. It was eliminated as part of AFY 25 and also eliminated as part of this 2026, as I think it maybe was a 2-year is why it showed up there. And then the big news is last year we did get the $4 million increase, and that was as a result of, again, Dr. Ashley presented the trauma system stabilization plan, and I'm here to really thank on behalf of our trauma centers. I think that was a huge boon to them, a real boost, and instilled a lot of confidence that trauma care was really a focus. And just so you can see how that shook out in the distribution, this is by trauma center level. So, and again, you always hear Dr. Ashley talk about the cents on the dollar, how much, because we have a lot of good data on readiness costs, and we have that all the way down to the level 3 and level 4 center level. First in the nation, nobody has ever done that or published that, and so a lot of other states are following in Georgia's footsteps with that now. So for the level 1s, 1s, 2s, and 3s are now, we're splitting everybody as the same rate or percentage based on what their readiness was. So for the level 1s, that bumped them from just under 500,000 to just under 900,000 for base readiness. And then you can see for 2s, just under 300 to 431. And then for level 3s, who for a long time, level 3s and 4s were just funded at a stipend level. But now we went back and looked, based on what your increase was last year, we went back and looked at what the funding formulas were, and we revised the formula so that there is a percent distribution and not just stipend levels that stay stagnant over time. So the level 3s are now 8%, and they are at 150,000. And then the level 4s, unfortunately, with our readiness cost data, we didn't get a whole lot of data from the level 4, so we will definitely need to increase that again in the future and provide more support and figure out how we can get true accurate costs, because again, that's really where our gains are going to be. So we're funding them, and we mentioned in the stabilization plan our goal was to really make sure we stabilize these rural centers, so we're funding them at 50% of what we know their cost, their average cost to be, which was 80,000. So we're funding them at 40. And that's all I have for you, if there's questions. I do have also a one-pager in your packet, because I usually always try to come with a one-page summary for things that we don't get time to talk about.
Thank you. You do have a question, Representative Bennett.
Thank you, Madam Chair. I have an easy question for this time of the evening without counting all these red dots. How many level 1 trauma centers are there in the state total?
You would think I would know this off the top of my head, but I did flag my page. Just
Okay,
in
he
case you
counted
asked me.
quickly. Chairman said 1, 2, 3, 4, 5, 6. Is there 7?
All of the dots might not show up because there's 6 adult level 1s, and there's a pediatric level 1 center here in Atlanta, of course, you know. Yes.
Okay, thank you.
Yes.
I don't see any other questions. Thank you very much for your presentation and the great work y'all do. Thank you.
Thank you, Madam Chair.
Okay, the hour is late, but we are going to take a quick 5-minute break. And anyone that has not signed up and wants to speak, please come up and sign up, and we will start in 5 minutes. Anybody needs a quick break? Thank you.
She's
That's been a quick 5 minutes. We're going to go ahead and get started. I'm going to ask everybody, when you go to the podium, to please introduce yourself and who you're representing. And we're going to try to keep these brief. The hour is late, and I think everybody's looking for that. So if you would keep it between 1 and 2 minutes, 2 to 3 minutes at the most. Okay. Tom Bauer?
Yes, ma'am. Can I give you these? Should look familiar to you. Thank you, Madam Chair, members of the committee. I'm Tom Bauer with the Georgia Occupational Therapy Association. I think I've touched base with everybody who's still here. We're here to ask for an issue that this committee has been good to us for 2 years on, which is the funding of Medicaid funding of occupational therapy assistants and PT physical therapy assistants, particularly in the Children's Intervention Services Program. You can see here that all of the states surrounding Georgia reimburse services, and this is, of course, not direct reimbursement to the PT or the OT assistant, but as you know, we have a workforce shortage issue here, and our private clinics have backups with waiting lists, and if we could have, and if our OTs and PTs, the clinics could get reimbursed for using OTA services, we could chip away at that backlog. And again, under managed care, these kids are getting delayed services, and they're the kids with chronic disabilities, and the more they get delayed, the more further they get behind. Also, the Children's Intervention Services, the school part of the program does reimburse OTAs and PTAs. I'll keep it at that, but I do need to issue an apology to you. I have given you this in the past, and the dollar figures I left off this time because there seems to be some confusion. Representative Gamble had actually made some inquiries for us with the Department of Community Health, and they came back with a figure of about 5.8 million, and I misread it and thought that was the total rather than the state share. Last year, this committee and the House and the Senate both put in a total of 4 million, 1.3 in state funds. So when I looked at that 5.8, I thought it was just a little bit more. So what DCH right now is saying is that this would cost 17 million, and of course that's a lot different than the 4 million last year. So I've been talking to Morgan Hall here, and I'm going to get with DCH because it really doesn't make any sense to me how the number of claims would be so significantly different in that 4 million. But we still think it's a very strong way to address the workforce issue, and want to work with you on getting the right figure.
Thank you very much. I appreciate that.
Thank you.
Next up will be Chairman Mathiak.
Thank you, Chair Lady. I so appreciate the time today. Today I'm asking for funding for Duchenne muscular dystrophy pilot program to help with identifying babies with this syndrome. The Georgia lab has equipment capable of screening newborns and Duchenne's without the need for additional blood spots. So that's what we're trying to fit into this program. When we get a confirmatory DNA testing, it's included, Duchenne's is included. The big thing that we're finding is the false positives are nearly zero. This was something that we had talked about in the past, and that was a concern of our committees. The federal government has looked at that, and the more the it's come down to a zero program, or zero testing. So we're excited about that and happy that that's been there. The pilot program we would like to start in April. And the further we delay these children being diagnosed, the longer it takes. Obviously, it takes longer to help them. The sooner we help them, the quicker they can live a better life. Over 85 medical specialists throughout the country have endorsed the Duchenne's newborn screenings, and we're excited about that too. DPH's project for these screenings, the program cost is about $843,772. So you can see that's not a small amount of money, but it's very needed for our children. So if there's anything else I can tell you, I would love to.
I don't see any questions. Thank you very much for your presentation.
Thank you for allowing us to at least have the ask today.
Thank you. Next up will be Kelly Ball.
Good afternoon, Madam Chair, members of the subcommittee. My name is Kelly Ball, and this is Caroline Bowman, and we're speech pathologists. We're here today representing not only our own practices in Decula and Statesboro, but the Georgia Speech Language Hearing Association as well. We're here today to ask for a rate increase to CPT code 92507, which is our speech therapy code, and this would be in the Department of Public Health's Babies Can't Wait program and in the Department of Community Health's Children Intervention Services program. Last year, we were grateful to receive a small increase to this code. Today, however, we're coming back to ask for additional funding. 92507 is our most frequently used code, and 1 unit of this code is billed for every session. Last year, we did receive a rate increase of $3.11 to this code, and this is the only increase we have had since fiscal year 2007. We're asking that the rate be increased to the 2025 Medicare Atlanta market rates for parity of rates paid for services. We're finding it increasingly difficult to hire therapists to work with Georgia's children, especially in rural areas, as those working with adults are paid more. By moving this code to the 2025 Medicare Atlanta market rate, it would change our rate from $65.64 per session to $75.07 per session, which would be an increase of $9.43 per session. Thank you for the opportunity to speak, and I'm happy to answer any questions.
Thank you. I don't see any questions, and thank you again for sharing this information with us.
Thank you, Joe.
Thank you. Next would be Jillian Brazil.
Good afternoon, Madam Chair and the members of subcommittee. My name is Jillian Brazil, and I'm the Director of Graduate Medical Education at St. Francis Emory Healthcare in Columbus, Georgia. I am here to request funding for 7 additional resident psychiatry slots that we will have starting in July 1st of 2025. The total amount that we are requesting is $178,069.64. You'll likely recall that St. Francis began its GME program in 2022 with our internal medicine residency. We currently have 30 internal medicine residents and 14 psychiatry residents. We will cap out at 28 within the next 2 years, adding 7 in each of the next 2 years. Again, we are grateful for the current and past support of our programs, and I'm happy to answer any questions regarding this request for the funding for the additional 7 psychiatry slots.
I don't see any questions. I appreciate, again, you coming and sharing this information with us today.
Thank you.
Thank you. Next will be Nancy Petra.
Good afternoon. My name is Nancy Petra, and I am the Director of Government Affairs for the Alzheimer's Association Georgia chapter. And in your packets, you do have a kind of sheet on our funding request within the Department of Public Health. As the largest nonprofit funder of Alzheimer's research, the association is committed to accelerating the progress of new treatments, preventions, and hopefully one day a cure. And a key factor in research is data. Health registries collect valuable data on disease progression, risk factors, treatment outcomes, and provide insights for researchers and healthcare providers and policymaker decisions for supports and services. The Alzheimer's Disease Registry at the Department of Public Health was originally funded 10 years ago with $110,000. So here we are a decade later, and that funding will cover a part-time epidemiologist and a contract with CMS for Medicare data. As treatments have been approved by the FDA that can slow the disease progression, it's time to invest in the registry so that the Department of Public Health can add data on early diagnosis, young onset diagnosis, track treatment progress, and understand how and if it is changing the burden on our communities in the state. For these reasons and others that I have listed in your packet, the Alzheimer's Association is advocating for an additional state investment of $595,000 to add staff for the registry and to keep up with the increasing cost of data. The $595 will give us 3 staff, which will be a full-time epi, a data manager, and a field recruiter that can go out and work with health systems and doctors to build the data infrastructure that we need to collect good data. This budget request is also supported by several of our community partners, including the Georgia Senior Living Association, the Georgia Council on Aging, Leading Age Georgia, and the State Long-Term Care Ombudsman. Thank you.
Thank you very much. There are no questions. Next would be Devin Creel.
Thank you, Madam Chair. Good afternoon, committee members. Madam Chair, we've been in front of you before. This is just a quick follow-up, and you have 2 handouts in your packet. This is a funding request for the Safe Haven program that was signed into law last session with the passage of House Bill 455. The program aims to prevent stress burnout among healthcare practitioners, specifically those that fall up under the GCMB, the Nursing Board, as well as the Pharmacy Board. Safe Haven provides a confidential support system for clinicians facing burnout, stress, and mental health challenges without fear for repercussions to their careers. Research also shows that stress and burnout increases the risk of medical errors by up to 200%. Safe Haven is a voluntary preventative initiative that complements but does not replace the physician health program. Its goal is to reduce burnout, improve mental health, and help practitioners focus on patient care.
Thank you. Again, there are no questions.
Thank you.
Thank you. Next would be Laura Bracey.
Good evening, Madam Chair and committee. I'm Laura Bracey. I'm the Government Relations Director for the American Heart Association. And today I am advocating for funding for the Department of Public Health to expand a produce prescription program, which is a research-based program that identifies people with diet-related chronic illnesses and food insecurity and prescribes locally grown produce, nutrition classes, and cooking classes. These programs have been shown to reduce high blood pressure, reduce BMI, and increase produce consumption. Not only would expanding produce prescriptions be good for health, but also would support our Georgia farmers. A $500,000 appropriation would mean that the Department of Public Health could expand the work that is currently happening in Augusta and Clayton County into rural Georgia. Thank you.
Thank you very much. There are no questions. Kathleen DeHaan.
Thank you, Madam Chairman and members of the committee. I'm Kathleen Tehan with the Georgia AIDS Coalition. At the end of 2022, the Department of Public Health released its viral hepatitis elimination plan. Viral hepatitis is a critical public health concern that can lead to lifelong health consequences, including cirrhosis, liver failure, liver cancer, and death. The elimination plan was the state's first strategic response developed to combat viral hepatitis A, B, and C statewide. Georgia has continued to see increases in both acute, new, and chronic hep C infections in those aged 40 years and younger, primarily due to increased opiate epidemic. This includes increases in hepatitis C infections among females of childbearing age, increasing the potential of perinatal hepatitis C infections among infants. This can increase maternal and infant morbidity and possibly mortality. Georgia continues to identify, on an average, approximately 100 new B infections each year. Increases have been seen among those injecting drugs. Georgia also experienced a hepatitis A outbreak that lasts from 2018 to 2023, resulting in over 2,000 infections, primarily driven once again by those using drugs. This emphasizes the continued need to promote hepatitis A vaccinations, the new universal hepatitis B vaccination recommendation for adults 19 to 59 years of age, new universal hepatitis C screening recommendations of all adults over 18 years of age, and for females during each pregnancy, routine hepatitis B screening for adults 18 to 59 years of age, and linkage to care and treatment for those chronically infected with hepatitis B and/or hepatitis C infection. Due to funding limitations, the Viral Hepatitis Division cannot fully address the challenges and barriers to increasing viral hepatitis vaccinations, screening, and linkage to care and treatment. Resources are needed to improve hepatitis B and C surveillance and epidemiology, promoting routine hepatitis B and C testing and increase linkage to care capacity statewide. I believe in your packets you have a fact sheet.
Yes.
And we are looking for about $3.2 million.
Thank you very much. You don't have any questions?
Thank you.
Appreciate it. Thank you. Next would be Andrew Johnson.
Good afternoon, Madam Chair, members of the committee, budget staff. Thank you for your patience through the day, and thank you for letting us be here. Here on behalf of Applied Behavioral Analysis providers for the treatment of autism spectrum disorder. We represent a specific provider, but what I'll talk to you about today would help all providers of ABA therapies. We're requesting $12.5 million in state matching funds. This across 4 CPT codes: CPT 97151, which is an assessment code; 97153, which is a treatment code; 97155, which is a treatment code; and 97156, which is a treatment code. So currently these services are provided in bricks and mortar. They're provided also through in-home and telehealth modalities as well. They're provided throughout the state. They're provided by physicians, APRNs, psychologists, BCBAs, which are board certified behavioral analysts, assistant BCBAs, and RBTs under the supervision of BCBAs. The last Medicaid rate increase for these was in 2019. So as you all know, this is a important service, and there's a lot of kids that are needing these services, and so it's been about 6 years since we've last seen an increase. To compare to one of our neighboring states, North Carolina, they have about 10% higher rate than we have here in Georgia. And so as some of the previous presenters have highlighted, when it comes to workforce challenges and us trying to recruit providers, to Georgia, as opposed to who might be attracted to neighboring states for more attractive rates, we want to get some parity with these rates. Cost of employment is significantly higher than it was 6 years ago, as we all know, and has been demonstrated many times. And so happy to take any questions, and happy to speak further on anything you'd like.
We don't have any questions, but I appreciate your bringing this information. Thank you.
Thank you.
Next would be Rick Ward.
Thank you, Madam Chair, members of the committee. I'm Rick Ward. I'm with the Georgia chapter of the American Academy of Pediatrics. But today I'm here as part of a coalition. You'll see from our letterhead being passed around the Patient-Centered Physicians Coalition of Georgia, which is made up of the 4 primary care specialties: family medicine, internal medicine, pediatrics, and OBGYN. And these 4 specialties, as you might imagine, provide the bulk of medical care delivered to all Georgians, from newborns to seniors to every age range in between. Anyway, this is a request for keeping our rates in Medicaid somewhat similar to Medicare. And so we're asking for $19 million in state to raise 2 of the most common codes that primary care physicians use up to last year's Medicare rates. One number I'll leave you with: there are 11 million Georgians. You all know that. There are about 11,000 members in our coalition. So if you do the math, that's 1 doc per 10,000 people. That's not a good number. So, and I think the committee has done a wonderful job of drawing the connecting dots between a strong Medicaid program and strong economic vitality in these communities. Thank you, Madam Chair.
Thank you. There are no questions. Thank you. And our next presenter is Doug Rennick.
Thank you, Madam Chair. My name is Doug Reinecke. I'm here representing the Association of County Commissioners of Georgia. Greatly appreciate y'all's time, and I'll be brief. We stand before you today to request the committee approve a 10% increase in Medicaid reimbursement. The request would be a cost of approximately $3.7 million for the state. This would result in a total increase of $10.9 million with the FMAP federal match. 2018 EMS services received a 7% rate increase that was specific to A0427 emergency transport code. The remaining codes have not been updated for 20 plus years. So this is a request that is supported by ACCG and our 159 members, as well as the Georgia EMS Association. We ask for your favorable consideration and happy to answer any questions.
You have no questions. I appreciate your bringing this to our attention.
Yes, ma'am. Thank you.
Thank you very much.
I appreciate it.
That ends our people on the list. Are there anyone else here that would like to make a statement before we adjourn? I see no one, and this completes it, and we are adjourned.